So we have Joanne Spetz and James Kahn here from the Institute of Health Policy Studies at UCSF, and they are going to talk and do this debate back and forth on some current healthcare reform legislation and each take a side. Joanne and James are just going to take a few minutes to get mic'd up here, and then we will get going.
My name is Jim Kahn. I am a professor of health policy, epidemiology, and global health at UCSF. I've been here since I did my postdoc, 1989 to 1991. Most of what I do is research on the cost effectiveness of prevention and treatment programs, which means looking at the evidence that others have accumulated on the risks of disease, on the effectiveness of interventions to reduce those risks, on the costs of implementing those interventions, and then putting it all together with computer simulation models. Most of my work is global, and most of it is in HIV. So I've done a lot in HIV prevention and treatment, including, of course, antiretroviral therapy, as well as cotrimoxazole, a drug at the different end of the cost spectrum. I've also looked at gestational diabetes and various miscellaneous other problems in other disease areas. In my day job, I'm a skeptic. I'm a health economist who says, someone comes and says, we have this great intervention, this works, it's worth it. Then I sit down and go, well, what's the evidence? How well does it really work? How much does it cost? Does it really get you benefit? I've done some work on mHealth, for example, mobile health. Okay, you've got the cool technology. It's cool, no doubt about it. You can do your cell phone to do things that we never anticipated. But what does it really get us in terms of health, and is it worth it? So I'm the guy that says there is no free lunch for most of what I do. So when I tell you in a few minutes that single payer is an amazing option, it's not because of my characterological nature, Joanne. It's because that's the truth about the policy.
Well, we'll get to the debate in a few minutes. So I'm Joanne Spetz. I'm an economist, dyed-in-the-wool, trained at Stanford Economics Department. I've been at UCSF since kind of full-time since 2001. I'm also at the Institute for Health Policy Studies primarily, just kind of across the suite from Jim's office, and am a professor of economics there. Most of my research is on health workforce issues, but I've also done a lot of work on healthcare organization and taking the broader perspective of how is the healthcare delivery system organized, who are the workers, the hospitals, the different organizations that are involved in delivering care, how do they interact with each other, and how does that influence what we get in terms of quality and costs. And so I do take both the idea that quality is important, but also that we have a limited budget and we have to work within that budget and figure out how to get there, and that the organization of how we try to do that is extremely important to what we get in the end in terms of quality and cost.
So I am going to subject you to some PowerPoint slides. So Joanne is kinder, and she said she won't. But I'm going to take advantage of the fact that you've had your coffee, you're bright and teary-eyed, and you can see some PowerPoint slides. I have to start any presentation at UCSF with a little lineage or trajectory of health. This is, of course, LBJ signing the Medicare Act. Does anyone know who this is? Joanne? That is the young Philip R. Lee, Assistant Secretary for Health at the time under Johnson, and very much involved in the Medicare rollout back in the day. And when he came back to UCSF and became the chancellor, which is a picture I don't have here. No, this is about what he looked like as chancellor. And he was chancellor for a few years, and then he started the Institute for Health Policy Studies, which is where Joanne and I both work. And one little tidbit, which doesn't relate specifically to single payer, but I think does illustrate for me, one of the virtues of moving toward universal coverage is that Phil used Medicare to advance social justice. Phil said, hospitals want to tap into Medicare dollars, they have to integrate the wards. No more black and white wards. And in a flash, with one regulation, he accomplished what had been getting rid of a problem that had been persistent for many decades. So I do see single payer as an opportunity to advance our broader social goals. I'm not going to talk about that anymore, but that for me is an important context. My argument will be that when it comes to healthcare financing, there is such a thing as a free lunch. Single payer will provide better care and at a lower cost. And I'm an evidence-based guy. As I told you, this is my day job. I look at all the evidence. What we see is that universal coverage with a comprehensive benefit package that is just a single package with truly streamlined administration leads to higher access to care, more utilization, better health outcomes, and lower costs. That's what I hope to show in the next 12 minutes or so. Key features of our US healthcare system: we spend close to 18% of GDP on healthcare. Most of our care is federally funded. 43%, that is under the Center for Medicare and Medicaid Services. Medicare is for the aged and disabled. Medicaid, which is a state-federal partnership, is for the poor and also for long-term care. You have the Veterans Administration, military healthcare, many other specific services, and state and local safety net. We calculated in California roughly 65 different funding streams to pay for care in the public sector. Private sector is about 34%. Most of that comes via employers, and families contribute about 1/3 of the 34%. About 15% are uninsured, and there are other private mechanisms that represent about 7%. So we have a mixed, heavily public system, and actually, if you calculate in the cost, the tax incentives for employment-based care, it comes out to about 60% of what we currently spend on healthcare in the United States is public, which is more than any other country spends on all healthcare. Our spending per capita overall is about 50% higher than the other OECD countries. We have generally fewer doctor visits and inpatient days. The difference in spending is price. We pay more for doctors, nurses, procedures, and drugs. We use more high technology, more MRIs, for example, and we spend a lot more on administrative costs. This is a special interest of mine. I'll return to it later. Our health outcomes are the same or worse. This is a graphic from National Geographic. What you have is countries listed here. The position on the left scale is spending per person. So this red line, which goes way up here into the ceiling, you can't see, that's the United States, and these are the OECD countries. Then on this side, we have the life expectancy. So our life expectancy is kind of in the middle of the bunch. And then the thickness of the line is the frequency of doctor visits. So you can see by this visualization, we spend a lot, we don't have especially good life expectancy, and we don't have very many doctor visits. This is a historical view. You can see that back in about 1970, the US was leading the pack on healthcare spending per capita, and then forged ahead to establish an extremely large lead against all the other OECD countries. This is the result of letting the market be the approach to healthcare in the United States. We don't have a pure market system, but we have a substantially market-based system, and this is the result. Canada, which was very similar to us in expenditures back here, took a very different course when it switched to single payer in the 1960s, starting in Saskatchewan. The number of uninsured in the United States has been rising steadily. It reached up to about 50, and just the report came out the other day, it took a small dip to about 49 million people. So the effects of the Affordable Care Act are beginning to show, but even with full implementation, it is expected there'll be about 30 million who remain uninsured, and arguably many who will be underinsured. They'll have insurance, but it won't be particularly good. The lack of insurance varies by group, and in particular here we see Hispanics, a group that's very important in California, has a very high rate of uninsurance. Our standing on healthcare outcomes is pretty dismal. The United States ranks worst on low birth weight, infant mortality, and years of potential life lost. Age-adjusted mortality, we're kind of here near the bottom. We do worse, especially at younger ages. The good news is if you reach 80, you're in pretty good shape in the United States. The Commonwealth Fund has done some very interesting research comparing the experience of healthcare in different countries. Kathy Schoen is the leader of that effort. And here you can see here, for example, having a regular doctor. In Germany, 97% of people report having a regular doctor. In the US, the lowest number in the survey, 84%. With the same doctor for 5 years or more, 78% in Germany, 50% in the US. And again, the OECD countries all have some version of universal coverage, either a pure single payer model or some other way that everyone gets the same coverage. Now, I think a lot about administrative costs. I've done some research on that. This is our current system. You have funds, money coming from employers, from premium contributions by families, income taxes, and also out-of-pocket spending. Then you have multiple payers, so insurers, both public and private. Many private payers, you have Medicare, Medi-Cal, S-CHIP, et cetera. This money, in some fashion, goes into these pools of payers. And then what you see is a set of arrays of arrows. Each of these payers pays each of these providers, the doctors, the hospitals, the pharmacies, and so on. If you turn that around, what that means is if you're sitting in a pharmacy, and you guys probably know this better than I do, although not from Kaiser. Kaiser has many single-payer features, and so I feel like I'm speaking to an audience who understands the perspective I'm presenting. But if you're not at Kaiser, if you're running the Safeway Pharmacy on College Avenue, you have to deal with a lot of different payers. And so that's why you have these arrays of arrows. And the research we've done shows that that's expensive. Administrative costs overall in our system are about 30%. Some of that's, human resources, medical charts, and scheduling and all that kind of stuff. But half of it is to administer the insurance. So we spend about $400 billion per year in billing and insurance-related administration. That is about $1,300 per person per year in the United States goes to moving the money around. About 60% of this is at providers. So we read about the profit margin or the medical loss ratio at the insurers, but what's really driving it up is that the providers, whether pharmacists or doctors or hospitals, have to deal with all of these payers, and it's very expensive. An estimate, when I did this slide, is about $250 billion is excess. It's avoidable. We're updating this number. I'll send you the new slide when we have it. But it's a big number. It's a significant chunk of our spending. Why does this happen? Because the insurance process is extremely complex. I'm not going to read this list. I purposely kind of had it fade off here because you can imagine that it's really about lots and lots of detail that has to be juggled by providers in association with the payers. When you add it all up, for every dollar that goes through the private health insurance system, 62 cents ends up as medical care. 19 cents goes to the insurer for profit and administration. About 4 cents goes to the hospital. BIR means billing and insurance-related administration. 5% physicians spend on that. That's about 14% of physician income, but 5% of the total pie. And then general medical care administration is 10%. So you spend $1 on private insurance and you get 62 cents of health care. So what do we do about this? There are different types of healthcare reform. One approach is to improve the free market. Joanne will talk about that. There are various strategies. One of the guiding principles is that if you have skin in the game, as a consumer, you'll use less healthcare, and that will help control costs. There are various problems with that, which I will address perhaps in my rebuttal. You can try to improve the existing system, which is what the ACA does, or you can go to single payer, which is to use a public fund to pay for privately and publicly delivered care with everyone covered with a single good benefit package. The Institute of Medicine has suggested some criteria for judging healthcare reform: universal, continuous, affordable to the individuals, affordable to society, and enhancing health and well-being. I don't want to spend too much time on these, but keep these in mind as you look at the options. Do they meet these criteria? This is single payer. Single payer, you have money coming from multiple sources, but then only one payer pool, and therefore only one array of arrows. What that means is that if you're a doctor or pharmacist, you're dealing with only one payer. You have one billing form and one process. And by the estimate of various people, including me and my colleagues, is that would reduce the administrative cost of insurance from 15% of the total to something less than 5%. There is a big savings to be had here. The way a single payer works is you have universal coverage. Everyone is covered from birth to death, from cradle to grave. There's no eligibility determination except that you live in the state or in the US, depending how it's implemented. There's no marketing, there's no underwriting. There's a single pipeline for payment. You have a fully standardized benefit package, and reimbursement rates are simple. You have one billing process. Everything gets billed and paid simply. Single clinical practice rules. Most importantly, in the pharmacy setting, you have one formulary. Right now, doctors have to deal with multiple formularies. Do Kaiser doctors have to deal with multiple formularies?
No.
No, they don't, and that's a great advantage of Kaiser. But everywhere outside of Kaiser, docs have to deal with multiple formularies. Well, in the VA, which is basically a single payer system, they don't. But where they have to, it's incredibly inefficient. So you have this process simplification, incredible process simplification, what I call the 3 C's. You're culling, so you're taking away from our current complex processes, enrollment and eligibility determination and other processes. You just say, we don't need to do that anymore. You're consolidating, so benefits are now one benefit package. Billing is one billing process, one formulary. And also, importantly, the community orientation. Single payer would not allow for-profit payers. It would allow for-profit providers, but not payers, not insurers. If you make these kinds of changes in administrative costs, you get savings of about 12%. Again, it's that number I mentioned before, something like $250 billion. Some people say we can't make the change. We're here, we are, there's this historical path, we're on this path, it can't be done. But Taiwan did it. In 1995, they decided that they would go from a mixed public-private system, just like we have, and go for single payer. And they did it, and in the process, they reduced administrative costs to 1.5%. They reduced deaths from amenable causes, that is, deaths for diseases that can be managed in the outpatient setting with deaths prevented, or ambulatory care sensitive diagnoses, to use a term that Andy Byman from here has often spoken of. They fell faster with the onset of national health insurance than they had before, with no change or little change in non-amenable causes. In other words, there was evidence that doing this not only saved money, but it improved health. And as a last slide, we're in the process of writing up a comparison of the specific features of the OECD health financing and organization systems, not just the overall universal coverage versus not, but specific features. And one of the things we looked at was drug formularies. And what we found is in 12 of the 14 OECD countries which we examined, there is a national standard formulary. In 2 countries, that was not true. This is the United States, sorry, red is the United States, and this is the Netherlands. And so we think that, you know, single payer is talking about how you pay, but it's also talking about making processes that are logical, reasonable, smart, simple.
All right. I did not prepare slides because I more wanted to outline a philosophical and broader strategic approach rather than, and I figured also most of the data that we'd want to see he'd already put up on the screen because he's, you know, gets into that detail. I've seen his materials on teaching this cost effectiveness class, and it'll make anybody's eyes go, oh my gosh.
Hey, I got really good ratings in that class.
I believe it, actually. You know, it's pretty amazing when you can make stuff that seems so complex actually look very simple. And for the students in there, they walk in going, you know, how are we going to do this? And they come out of it actually understanding how to do those decision trees, which is good stuff. So I think a first thing to put on the table now is that what the United States has is not a market-driven system, right? We have a system that has a lot of government control in ways that are really prevent competition in the ways that we would want. And I think the Affordable Care Act honestly does not help a whole lot in fixing those problems. I would guess that we would agree on that the issues about where insurance companies are not behaving competitively are not really affected by the Affordable Care Act. Areas where providers are able to keep control over kind of their little piece of the financial pie by not allowing, say, nurse practitioners to practice more freely, those things aren't changing. So there are a lot of things that are not competitive in our market. And I believe that market reform can work, but it needs to actually be done properly. And you really have to kind of go all the way there, because if you only go part way there, or you basically let the insurance industry control everything too much, you're not going to get the kinds of outcomes in terms of improving cost and quality that you want. So here's the outline. So the main problem with health insurance and with the healthcare system is that insurance is a natural response to risk. So if you, did any of you take like an Econ 1 type class? And somewhere in there they might have talked about expected utility, you remember that? And the expected utility and how you respond to risk. When you have risk, it works out that you want insurance, and that you end up being better off having insurance, even if dollar-wise over the course of 10 years you might spend a little bit more for the insurance than you end up in claims, because you've been able to take that risk out of your decision making. So that's from an underlying economic standpoint, people want insurance to avoid financial risks. So you have auto insurance, not because you think it'll keep your car from getting in a wreck, and usually not to cover your daily or annual maintenance of your car or pay for your gas. You have it in case you have an accident or your car gets broken into, so that you get reimbursed for dealing with that. Now, why people have it in their heads that health insurance is somehow supposed to keep them healthy is a little strange, right? Health insurance should be like any other insurance. Does anybody expect their homeowner insurance to keep their house from burning down? Of course not. So why would your health insurance have that role? Now, it is true that some organizations like Kaiser Permanente have taken a different philosophy, and I think that can work in a market approach. But the fundamental purpose of insurance is to protect people from financial risks. And given that that's the purpose, right now the way our system is designed, it really doesn't emphasize that. And it also does not encourage people to make choices that are balancing those financial desires or those financial issues with the other decisions that they might need to make. So once people have insurance, the problem that comes from insurance is that now every time you go to the doctor, you pay just a copay. If you go to the hospital or the emergency room, you pay for, at least my plan at Kaiser, I pay, what, $50, I think, if we don't end up with a hospitalization. So I know that an emergency room visit costs a lot more than $50, but every time I go, I only pay $50. Every time I see the doctor, I pay my $15 copay. So on the margin, I have less disincentive to go every time, right? The kid's got a sore throat, may as well go, it's only $15. As opposed to if you really were paying for that, if you said, you know, I'm probably gonna take my kid in for a sore throat twice this year, that's probably gonna cost me $300, I'm just gonna budget for that. But instead, I'm giving the insurance company money for something that I should be able to budget for. So that's kind of the weird thing about the way health insurance functions. It does mean that people tend to seek more care than they would seek otherwise, because they're not paying the full out-of-dollar expense. And it doesn't matter if you have single payer or if you have a market-driven system. At that point, you have to decide how you're going to control that cost. Now, Kaiser Permanente does it through a whole variety of strategies, which generally, from what I can see, don't involve telling the doctors you cannot let your patients do X, Y, Z. But you know, there's a lot more education, there's a lot of system improvement there. In the private insurance sector, it's not entirely clear that they do any of that very well. And honestly, in truly single-payer systems like the UK or Canada, the way they do it is they just say, you can't have it, right? You can't have it, or if you want to, I guess you can get in your car and drive to Seattle and go pay them cash. Or if you're in England, I don't know, you get on the Channel and you go try to find some place that'll let you do what you want. You know, you don't get that choice of how to control that cost yourself. Those decisions are then in the bureaucracy. And I'll talk about my issues with that in a few moments. So how can you control costs? given that this is kind of the fundamental problem, and keep your quality up, which the US has done really badly on also. The two basic strategies are the single payer strategy and a more market-driven approach, which is making people more sensitive to and aware of the cost and quality decisions that they're making. How do you do that? It's the skin in the game, as Jim said. It's making people aware of what these costs really are. And in our system, people are not aware of those costs, largely because they are not seeing how much health insurance really costs. Right? I think right now the average cost of health insurance for a family is something like $15,000. Is your employer paying that out of the profits that they would otherwise give to their shareholders? Of course not, right? It's essentially coming out of your salary, right? You're earning less money in your salary because of that, but you have no idea. Most people have no idea how much health insurance costs. They have no idea how much their employer paid. They have no idea that if they pick Blue Shield's PPO versus Kaiser, that it's going to cost their employer $3,000 more a year, or whatever that difference is. People just have no clue how much this stuff costs. Then they have all these co-payment things on top of that, so then they really don't know, even for every single visit, how much it truly costs. So how can people make good decisions, and how can people trade off cost versus quality when they don't have any idea how much it costs? So the first principle of going to a more market-driven approach is to get people to see those costs, and that does not necessarily mean getting rid of employer-sponsored insurance. But what it does mean is getting rid of some of the tax breaks that employers get for providing insurance that mean that they can get a huge tax break for providing very high-quality insurance to people, much better than anybody would ever probably choose to pay on their own if they had to do it out of their pocket. Right now it's all tax protected, so you don't care if it costs $18,000 or $14,000 because there's a tax break and you never see it anyway. If you actually had to claim it on your tax form as I got this income and my deduction is really only $10,000 or $12,000 or $14,000 for my insurance, you're going to become more aware of what you paid, what that differential was. And some health insurance systems like CalPERS have gone so far in a very good way of saying, we will subsidize the cost of the lowest cost health plan in our group, and you're going to pay the additional cost, every single dollar of the additional cost of the more expensive plans. Or at least CalPERS was doing that for a while. I don't know if they're still doing it. So the idea is, if Kaiser is the least expensive plan available, great, we'll subsidize that. But if you want to buy the expensive plan, you're going to pay the extra $4,000, and you won't get a tax break for it. And that would make people more aware on that piece. Also, a lot of insurance companies have moved into areas of using what they call consumer-driven health plans. And do you know what those are? Yeah, it's like so not Kaiser. So what a consumer-driven health plan is a health plan that basically your insurance is really only covering the catastrophic costs. So it's kind of like your car insurance, right? You probably have a deductible of $500, maybe $1,000. Some people even have $2,000 on their car insurance deductible. So you have a big deductible, so you say to yourself, I've got to figure this year I'm going to spend $1,000 on health care. And if I start spending more than that, my insurance is going to kick in and cover me. So if I have something really bad happen, I'm well insured. But I need to budget for all these small costs. And so I need to budget for my pharmaceutical coverage. I need to budget myself for this. Gee, since I'm going to be buying my pharmaceuticals myself, I have a real incentive to make sure I get the generic, because it's your money at that point. And right now, if it's all insured, you don't care if you get the name brand or the whatever, right? You read these advertisements in the newspaper and you go in and you want the fancy brand name stuff, even if it, isn't any better than the generic. And so for most people who are privately insured, they don't see the cost difference of pharmaceuticals. They don't see the cost difference of, well, shoot, I may as well get an MRI on my knee today, even though I just twisted it a little bit yesterday, because I don't pay the $1,500 at that cost. But if you did have to pay it, you would care, right? You'd say, oh, maybe I'll ice my knee and elevate it for a week and see how it is, and then go ask for my MRI if it's still bothering me, because you've budgeted, but you're being aware of your budget. And that's the fundamental philosophical approach of really truly having market-driven health reform. So how do you actually get from here to there? The first thing is you got to let insurance plans really compete. Every state has established a whole set of different rules about insurance plans have to cover these benefits or those benefits. And the fact is, you might be able to get benefits that you would be perfectly happy with if you bought a health insurance plan that was licensed in Oklahoma, but the state of California right now won't let you buy it because the state of California has decided that we need to have all these different benefits mandated to you. Maybe you don't care about those benefits personally, or maybe if it's your money on the line, you'd be fine with a plan that was a little more like, a Ford mini car as opposed to getting the Cadillac. So eliminating these barriers to buying health insurance across state lines would increase the competition and give people more choices. The second thing is to let people really see the prices of the health insurance. And whether you're doing that through an employer-sponsored insurance or whether you're buying individually through like a health insurance exchange or ehealthinsurance.com or whatever your venue is, seeing what the prices are really will make a difference in people thinking about what benefits do I want, what kind of co-payment structure am I comfortable with, how much am I willing to pay. You could also look at quality ratings, right? I look at my quality ratings of the health insurance plans when open enrollment rolls around. There's a reason I'm in Kaiser. But people can make decisions. Some people just don't like the idea of Kaiser, even though we all try to convince them that maybe Kaiser's pretty good. But some people just don't like that approach. They just don't want it, and some people wouldn't ever go anywhere else. Give people the full range of choices, as opposed to saying one size fits all. And then the third piece is reducing regulations. There's no particular reason that a nurse practitioner should not be able to prescribe medications. There is no evidence that preventing NPs from prescribing or caring for patients independently has saved anybody's life. So regulations that don't actually have a very clear rationale in quality or safety should just be thrown out. End of story. So that people really can, again, see the price, make the decisions. This is actually probably especially true for the Medicare population, and you're going to hear very weird things about this year, but the notion that somebody on Medicare who's elderly should not see hardly any of the cost of their health care and be demanding that they're still getting cervical cancer screening when they're 90 years old is just silly, right? The idea that is a population, if nobody else sees the cost of their care, that is the population that should see the cost of their care and should be making a decision about, I could basically be spending this kind of money on a vacation, on helping my grandchildren go to college, on whatever, but because that population is so insulated from the cost of their care, they're going to bankrupt this country. And so the idea of an entitlement for that population, I think using more of a voucher approach totally makes sense. Of saying, we'll subsidize you as an entitlement up to this amount for a basic plan. If you want the Cadillac plan, dig into your pocketbook. Now, these ideas do not mean screw the poor. You still, in these kinds of approaches, can have a subsidy, just like you can have an earned income tax credit. You can say, yeah, we as a government, we as a society believe that we should provide a subsidy up to this amount for people to be able to get health insurance if their family is poor. Maybe you provide more for children. So you can make those social decisions, but still give people choices. Now, why does single payer not work? There are, I'm going to say, three major issues with single payer. The first is clearly our governmental structure has not figured out how to live within a budget, and most of Europe hasn't either. So the notion that you're going to have a single budget and you're going to live within it and you're going to make health decisions around that when Medicare is basically on its way to insolvency, because once people have this benefit, they somehow have it in their heads that they're not paying for it and demand more and more, that just does not work with the way our system is structured. And in other countries, you might have more trust of government, you might have more willingness to make those trade-offs, but culturally, this country, the way we trust our government or don't trust our government, which may be justified, that process clearly is too broken to think that it could work. The second reason is, do you really want your benefits managed by bureaucrats? Single payer sounds great if you've got Sebelius running it. What is single payer going to look like if Romney's running it? How about if Bachmann's running it? Bachmann seems to think that a vaccination can cause instant mental retardation. So, or if you really truly are pro-life, The idea of having government officials tell you that your tax dollars are going to pay for abortions may be morally abhorrent to you. So if you have a choice of insurance plans, you could pick the insurance plan that meets your personal values, your personal needs, and not have some government voting process force these kinds of ethical things upon you. And so that would be the major concern that I have with single payer for this country. Maybe it works in Taiwan, but about a quarter of the people there aren't even happy with it. So these are the concerns that I have with going the single payer approach, and why I think we really have to try a more true market approach. Now he gets to rebut.
Thanks, Joanne. A couple of easy targets for me. So thank you for that. A border. So I just sort of ticking off a few of the points. Border crossing to get care. Yes, it does happen. It's true. It's more in the other direction, though. More people go from the United States to Canada than from Canada to the United States. So if that's a measure of the desirability of the systems, then I guess the U.S. is better. I mean, Canada's better. Oops. Wait lists. Right now, we have wait lists by chance. If you want to get a surgery, if your surgeon is available and your insurance is good, you can get that surgery right away. Even if there are too many cardiac surgeons or too many orthopedic surgeons, given what's really needed. In Canada, the allocation of specialists is much more careful. There are far fewer specialists in Canada as a proportion of total docs than here. We have way too many specialists here. And when there are wait lists, they are explicit and transparent. So if you wait 3 months for knee surgery, or 6 months even, that may not be so bad. But you don't want to wait for the urgent surgery. So it's a much more transparent and fair and efficient system. Markets. I'm a great believer in free markets. I love that I can get the iPhone 5 because it's now out this week, and that's what Apple has done and many other commercial vendors have done is a testament to how well our system works. But it doesn't apply to healthcare, and it shouldn't apply to healthcare. One reason is for a market to work, you need educated consumers, and it's very hard to educate people about healthcare, about the quality of different healthcare options, about the true costs, when people are sick, they're in no state of mind to make educated, wise choices about what kind of health service to get. And the other reason that markets wouldn't work to control healthcare costs in this country is that 80% of what we spend on healthcare in this country is for the 20% of the sickest people. The sickest people, often people with potentially fatal illnesses, often in the last 6 months of life, they're not going to be making decisions to save a few dollars here or there. So even if you do reduce utilization a little bit by having people aware of costs, that's not the key to controlling costs. And all the studies that have looked at this find that people are very bad at distinguishing between care that will really help them versus care that really won't help them. So it's tough, and if you make this seem like buying auto insurance, it's not really going to control costs, and it will put people in a very difficult situation. The next point, drug prices. It is true that if people have incredibly good insurance, that they might buy more expensive brand name drugs instead of a suitable generic. I can tell you from my insurance that either way I'm going to pay a fair amount, even for generics now. But I might choose a generic. But again, that's not really going to make a big difference. What's really going to make a difference is drug price levels. In the United States, drugs are 2 to 3 times more expensive than elsewhere in the world. And the argument that drug companies offer is that they need those high prices in order to support research. But if you look at the detailed research on what they really put into developing new drugs, look up Donald Light. He's done some great stuff. And what they put in is far, far less than they say. And the evidence from other countries who have controlled drug prices and much lower drug prices is that they do just as much research, and more of their research is on truly new compounds, not me-too drugs. So it's a weak argument, and I think the real way to keep drug prices down is through negotiating between the system and the drug companies, as is done in the other countries. Joanne talked about the fact that health insurance, like auto insurance, is about financial protection. And I agree, that's part of it, but I would argue that that's not enough. That what health insurance should be about also is access to health care to improve health. It would be kind of like if with auto insurance, because if you got insurance, you would also get safe driving lessons. And that's actually not a bad idea. And as a result, you not only were covered in the event of an accident, but you had fewer accidents. That's the proper analogy. The issue that Joanne raised at the end sometimes comes up, which is that, well, sure, maybe single payer work in these other countries, maybe all of these other OECD countries, there is a different attitude about government and a different capacity of government to accomplish certain things. And I want to, there are 2 points. One is that we don't trust our government to do this, and that single payer would be benefits managed by bureaucrats. So I want to propose that if we were to move to a single payer system, it would change the way we think about government. Everyone would be in the same system. Right now, when we think about government health care, what do we think about? Medicaid, which is poor people, and Medicare, it's busting the budget, and it's not exactly true, but we'll leave it at that. So you have these little pieces, and they're kind of easy targets. But if everyone's in the same system, it might feel different. Well, how do we feel in general about protection from fires? How do we feel in general about police services? How do we feel in general about our highway system? How do we feel in general about Social Security? These are things which everyone's in the same system, and on the whole, they have very high levels of support, and people agree that they work pretty well. I mean, we may complain that police don't come quite quickly enough, but then it's not just some poor or old person complaining. It's everyone complaining, and there tends to be a reaction, a favorable reaction to that. So that's the theory behind a single payer, that everyone's in the same system, and I believe not only will it be an efficient system, but it will build trust, and it will build social solidarity. So again, back to the point I made at the beginning, I think it's not just about economics. Benefits managed by bureaucrats. I'm sorry, but right now my benefits are managed by bureaucrats. If I want to get a test, or if I want to get a drug that's off of formulary, then my insurance company has to approve that. And I have to go through a process, my doctor has to go through. I had a battle with my insurance company some years back because my doctor, I was getting a routine GI test, and he threw in another routine GI test at the same time. It took 5 extra minutes. And we spent, I don't know how many hours afterwards arguing with the insurance company about whether he should have done that or not. That's fighting with bureaucracies. What single payer does is it doesn't micromanage. Single payer says, you have these wide benefits. We trust doctors to make reasonable decisions with their patients about what's needed. If there is terrible evidence of abuse, if a doctor is doing an MRI every hour, or whatever indicators are set up, there may be questions about what's going on there. But it's, on the whole, a much more doctor and patient-centered situation. I go back to what's the evidence. The evidence that we have is entirely about how well a universal coverage, single payer, or very similar types of system work in wealthy democracies. There are lots of theories about how the market could work. Little data, I would say no data, that they actually, that these ideas which you've summarized, which various people have put forth, can actually work. We're in evidence-free zone when it comes to market-based solutions to healthcare. We're in evidence-rich zone when it comes to universal coverage and single payer. And I will end with a quote from a famous British statesman, a quote which is then repeated by my health economist colleague from Canada at appropriate moments. America can be trusted to do the right thing after having tried everything else first. That was Winston Churchill.
All right. So I've got 6 notes here. We'll see if I get through them all in my time period. Let's see, the border crossing one's an easy one, because if you're going to talk about border crossing, I think the numbers might be that more Americans go to Mexico to purchase supplies than go to Canada, quite seriously. Like, there's a lot of border crossing to buy pharmaceuticals and to seek out healthcare services and dental services and so on in Mexico, because boy, you want to talk about a pretty free market. That's a pretty free market down there, and the result is that if you have a provider that you trust, and people do work through social networks to find them, the costs are low, and you can get good quality, and people really can vote with their feet. So the border crossing argument actually, I think, would probably favor people going to even more of a free market system as opposed to going to the socialist system when they're seeking care. So that's easy. Wait list issues. The wait lists in the US are by chance, Jim says, as opposed to there being a systematic decision about allocating specialists. Now, certainly there's been plenty of research, and you've heard plenty of stories about waiting lists in the UK and the queuing in Canada, and when that's been systematic and logical and worked well, and when that has been simply because they can't get people to provide the care that they want provided, or they can't afford it, or they haven't been able to get the providers into the right towns. I mean, those countries still have a lot of those same allocation problems, the rural-urban distribution problems, and so on that we have in the United States. And at the same time, if Steve Jobs needed a transplant, he had some money. He was able to figure out how to get one sooner, right? And does anybody here think that if somebody who's very wealthy in England wants something, that they can't get it? I mean, these kinds of allocations do happen based on income, and that's not necessarily a bad or evil thing. We aren't trying to be the Soviet Union. And so recognizing that there should be a minimum standard of care that people have access to, and that we may believe that we're going to subsidize that in some way, but beyond that, people should have choices, still should be okay. Let's see, second area is on illness and whether people can make wise choices, especially at the end of their lives. The notion that a family can't make a wise choice or is going to have a hard time on the cost-quality decision, well, right now at that stage of life, most people are elderly, they're on Medicare, they're so protected from their choices and the full ramifications, not only in terms of the costs, but also in terms of just good decision-making about how do I want the last months of my life to look, right? How many stories do you hear about people seeking heroic cancer interventions for stage 4 esophageal cancer that really truly lowers the quality of their life? And if at some point in that discussion there was also a bit of, you could do all of these things, you could also seek the palliative care, these are the risks, these are the outcomes, these are the probabilities, this is how much money it's going to cost, the insurance will cover this much, but only that, but not that much. Those kinds of decisions should be left in the family's hands. With an awareness of the full ramifications in terms of the inheritance you might want to leave your kids, the amount of money you might want your spouse to have for their care, as opposed to really, what's the alternative? Truly single-payer system. At some point, a bureaucrat says, sorry, we're not treating it. You're basically saying, and I don't want to go with the whole death panels thing because I think that discussion was crazy, but saying, these decisions are not decisions that people can make rationally, I think is really not reflecting well on my confidence that people can make those decisions well if they are given good information and if everybody is incentivized to give them good information. I know in Kaiser, there are social workers who work in the oncology departments. And those social workers do help patients navigate that process if they have a recurrence that's essentially going to be terminal, about not saying, sorry, that's probably a terminal recurrence, we're cutting you off, but saying, here are the options, here's the full range of options, here's the trials we can help you find, here are the things that we can help to support your family, here's your choice, and now we trust that you will make a good choice. As far as I understand it from the friend of mine who works in that department at Kaiser Redwood City, nobody says you can't get this, even within a fairly organized system like Kaiser. Drug price levels. Well, yeah, drug price levels are high in the United States. Medicare hasn't done anything to control that. In fact, most of the marketing is to the Medicare population, which is in a single-payer system. So the idea that single-payer system will solve that problem, I think so far the evidence in this country is just the opposite, that nobody has the political will to actually go tackle that in Washington, so that is where the prices are the worst. Fourth issue, should health insurance be about access to improve health and not just focused on protecting you from risk? I think if you're trying to educate people about their health, there are other mechanisms to do that. You know, if you want to educate people about safe driving, you have driving school. If you want to educate people about improving their health, you can have public health programs. We kind of have lost track of that in this country, but you can have public health education programs. You can have screening programs. You can have these kinds of interventions to help educate people about good behaviors. That doesn't necessarily have to get tied up in insurance choices. And if an individual wants to bring those things together, such as in Kaiser, they could purchase that plan. But if they don't have to. And that would be the kind of choice that I would support. Let's see. Jim talked a little about the centralization issues. And that, you know, we do tend to like our fire and police departments. And I will point out that those are locally controlled. Those are not national, right? How do we feel about, oh shoot, I'm blanking out now. He can't remember OECD, and I can't remember the department that decided to raid in Waco, right? The ATF people. Right, how do you feel about ATF, federal, versus how do you feel about your local police department, local, right? Totally different feeling. How did people feel about California public schools before all the money was forced to go into a single state pot and then get reallocated and controlled by the state versus when it was all locally controlled? Right? We tend to believe in and do a much better job in this country with the locally controlled programs. Even in Canada, it's locally controlled health trusts. It's at least the provincial level. It's not truly national in that sense. There's not a national single bureaucratic system, whereas in this country, Medicare for All would be a national single bureaucratic system. And I would draw that analogy of we trust the government agencies that are close to us and that we feel are responsive to us, not the ones that are further away from us, because clearly those haven't worked very well for us. The last point in the management by bureaucrats, which is very closely related to that question about the local control versus national control. You know, the Medicare program in some ways does some good things. I mean, it definitely is an entitlement that the people enrolled in it are happy with pretty much because they can get anything that they want. That system also has resulted in more specialists because the way that the fees are made and established, the fees have continuously favored procedurally based care, which means more specialists, more reimbursement for specialists. The Medicare program has exacerbated those kind of problems in this country, not improved them or fixed them. Right? The specialist and the demand for that is no better there. I would argue it's even worse. And so that kind of a approach does not solve these fundamental problems that Jim has brought up. We have a lot of evidence that Medicare in this country has failed in all these different accounts. And the notion that if you bring it all into a single system and we'll all then feel like we have ownership of it and we're all going to need to then pitch in together to make good decisions as a country, I don't think we have a ton of evidence that that works for the way that this country's culture tends to work. Probably the best analogy I'll come up with would be Australia. Australia has a hybrid system. Australia at some point decided, and I think culturally Australia's got a lot of similarities to the US, right? A bunch of people who said, you know, forget you, England. So, you know, in their case it was prisoners, right? We're going to send you to the prison colony. Part of the United States was a prison colony too. So, so what do? They basically have a guaranteed basic health system, but people can buy private insurance to go above and beyond that, and a huge share of the population does. A huge share of the population chooses to buy a private plan that's above and beyond what the basic national minimum is. And there is a very healthy marketplace of public providers and private providers that to some extent compete against each other in that marketplace. So they do have a guarantee. And as I said, I think you can have a market-based system that provides some kind of a guarantee so that you don't have large numbers of uninsured people. But they do embrace the idea that people all want different things and that competition for that is good. So I would view that as probably more likely to work well in this country. It's worked pretty well down there, and nobody seems to really talk about it here. Go figure. Thank you.
Joanne, it seems as though when you have more options and more of a free market, that it leads to a more unhealthier society compared to a single payer, more of a controlled approach. It seems as though, according to Dr. Kahn's slides, those countries have healthier populations and maybe better life expectancies. What do you think about that?
I will agree that those countries overall, I think we have the worst of both worlds. And I think we would agree on this. We have this system that does not actually let people, kind of make choices in a lot of ways that maybe they should. And it also isn't single payer. And I think that worst of both worlds, right? So we have, 18% of the people uninsured at depending on which year of data you're looking at, you have these, or which state you're looking at. So you have high numbers of people who don't get health insurance. You have people who aren't making decisions based on choice or cost or any, or even having any idea what the quality of different health plans and providers is. And at the same time, we're not providing enough subsidies to actually insure everybody. So we kind of have the worst of both worlds. And so my argument would be that if you, perhaps have some level of subsidy, a voucher that guarantees a really basic, bare bones health plan so that people can get at least a minimum of care. But at the same time, give people choices, make people more aware, provide those educational opportunities, have people have incentives to feel like they have a choice and that their decisions really do matter, that you could get those better outcomes. And that you would be able to do that in a function that would be more aligned with the way Americans seem to like to make decisions. I wish there was really good evidence from a developed country that this could work. If it is going to work anywhere, it could work here.
Just a comment off of that, even people with good insurance here, Kaiser members, still have poor health overall. So is it really a function of not having health care, health insurance, or is it the choices we make in our society here in the United States?
I'll take that one. I think you're right. It's both. And I just saw Michelle Obama yesterday on the Oz show talking about the importance of diet and exercise, and she seems to be a great ambassador for that very important message. Yet at the same time, having access to primary care, having the same doctor over multiple years, and having good antenatal care and so on, all does help somewhat. But I fully agree, it's a much bigger problem than just how we pay for healthcare. I wanted to comment on your last comment. You didn't tell me ahead of time that you like the Australian system, because the Australian system has a basic foundational promise. This is everyone's covered with not just a minimum insurance plan, but a good insurance plan. And if you want to, so that's not pure single payer, but it's got a huge element of just the kinds of things I'm talking about. Everyone's got the same coverage. It's got a single formula. It's standardized in the ways that I believe give us this opportunity to have better health access and better cost control. So we come in thinking we're opposed, but we end up agreeing that down under might be the solution.
That's how I felt in terms of there's really no argument. You guys are both somehow saying the same thing where, why can't we have this single payer system as your foundation, but also have some level of choices that you could, just like what you said, Australia offers, okay, here's what's covered basic, preventative health, here's up to what we cover for certain disease states, and then if you want above and beyond that, you pay extra. Why can't we go towards that? Because I am quite concerned about putting all of the choices and making decision on individual, because that hasn't worked either. Because if you give a voucher and they say, oh, I don't want that, and if it's a credit, maybe they'll take that financial credit for whatever that period, but you can't predict when you're going to get sick. So then how are you going to handle people without insurance, without using that voucher? We're going to still be in the same situation.
Joanne may want to comment on this as well. Despite an opening down under, which we should talk about, I think we really are proposing very different things. With single payer, we're talking about a commitment of the government, whether it's implemented at the national level or in the state of California or separate states, and I didn't clarify that, It's a commitment that everyone is covered with a strong, single, basic health plan. They do not have to choose an insurance provider. The market system requires people to either choose an insurance provider or to choose to not have insurance. That's a basic difference with what we're talking about. I'm sure we find many areas of agreement, but is that a fair description of? Yeah. Okay.
Yep. Yep. So I'll go out of character. So, see, he gets to play the part where he really does believe this, and I actually have a history in doing this in various classes where I have been the single payer advocate and I've been the market driven advocate. So I'll go out of character and say that, you know, having an individual mandate, it would be much easier to just say, look, if you don't do anything, we're putting you in a pretty bad Medicaid plan. I mean, not like bad quality or we're going to give you the scary doctor, but we're going to give you a plan that's very bare bones, because trying to enforce an individual mandate is going to be a little bit crazy. And so having or saying, here's a voucher, if you don't do anything with it, you're at least going to get this. If you show up at the public hospital, we're not going to send the creditors after your family, right? You know, and so having some kind of a basic, we agree that there should be some minimum so that you're not in bankruptcy because you had a car accident and were in the hospital. Is, I think I would find it hard to imagine that very many people oppose that idea at all. Especially given that there is a social belief that you're not going to let that person die on the street. If you want to watch that happen, go hang out in parts of China. You know, you can see that happen there, where there isn't a social agreement that if you're poor, we're still going to take care of you. So once we have that agreement, then the question is, how do you finance it? And so an individual mandate is a way to do that. Another way to do that is to say, look, we're just going to presumptively enroll you all in this kind of bare bones plan. And then the question becomes about how much choice you're going to allow above that, how bare bones that plan is. And that's kind of the, I would tend to favor more of a bare bones plan and giving people more choices, and a more, the framework that Jim outlined would be more, England, Canada, where that basic plan is pretty rich, is pretty good, and relatively few people are going to want to buy above that.
Yeah, by the way, I'm completely in character. This is just, I'm telling you everything I believe. So you were given a harder job. You're a much better actor than I. I think the next time you do this great debate, we should make it, great debate part 2, which is how bare is that bare bones, or how rich is that basic package? Because that's kind of the more interesting question. If you accept the principle that everyone should be enrolled if they haven't decided to buy up.
Since Medicare was implemented in 1965, the costs have skyrocketed. It's a single-payer government system for a segment of our population. But administrative costs have not been contained. Costs continue to grow. I think initially it was projected to not exceed something like $12 billion ever, and now it's hundreds of billions of dollars. The other issue, you mentioned this 15% uninsured number, and excuse me, I'm well aware that's been debated. Even that number is hotly debated in different segments. I think this original data were that it was people that were without insurance at any time during that year the census was taken. So many of those may have been in between plans. Many of those people may not even be in the country legally. They may not be citizens. Many may be able to afford insurance but choose not to buy it. But even so, even if that 15% number is correct, that still leaves 85% of people that have insurance. And so we've embarked on this journey to sort of dismantle and deconstruct our healthcare system, which is serving 85% of our population, to meet the needs of 15%. And then, but you just mentioned with the Affordable Care Act, there would still be 30 million uninsured. So you're going from 15% down to 10%. So for that incremental gain, is this really worth all of this effort, and when in fact it may not result in the cost savings that are envisioned? I mean, there's no reason why they can't achieve these administrative costs and reduce fraud. There's nothing preventing anyone in the current system from doing those already.
The history of Medicare, indeed, you are correct. It's the projections of what it would cost were gross underestimates. But there are many reasons for that, including more enrollment, the changes in healthcare. So the right way to assess that is, how did Medicare do at controlling costs versus the private sector? And when you make that comparison, if you look at private insurance and what those costs have done over time, and Medicare insured services, and Medicare actually looks a little better. They both went up a lot. Our whole healthcare system has changed, but Medicare did a little better. And I would also say that even though it is indeed sort of single payer for one part of the population, the for one part of the population part is really important. I mean, part of how single payer works is that you have to really have everyone in the system, and also the administrative savings on the provider side, on the doctor side, and the hospitals and the pharmacists and so on, is from having to deal with only one payer. And if you just have Medicare, and it covers some substantial portion of the population, but you have 82 other health plans that you have to deal with, then you don't get the administrative savings there. You do get the administrative savings on the Medicare side. Medicare is very inexpensive to administer. Various estimates put it at 3 to 5%, which is far less than private insurance. So I agree with you, it's a mixed picture, but it's not a dismal picture for the Medicare experience. Some of us who work on single payer talk about a better term than single payer, since that's like the worst term in history and health policy. But maybe we should be calling it improved Medicare for all. That's another way to think about it. Your second point was about why do this for the 15% who are uninsured. That's a good question. One reason is that even among those who are insured, remember, we're lopping off about 10%, 12% in unnecessary administrative costs. And many of those people who are insured have inadequate insurance. They have limits, they have high deductibles. When you have high deductibles as a way to try to implement consumer-driven care, people don't seek care. So technically they have insurance, but they don't have great insurance. So it's both about bringing 15% of the people into the system, as well as improving the quality of the coverage for the other 80, or some portion of the other 85%. And then finally, you talk about health lack of, or sort of how do you get the number for 15% uninsured? And my understanding, and just read about that again, is that's the number who are uninsured at the time of the survey. If you ask, were you uninsured at all this year, the number goes up. I forget the exact number, 18, 19%. And if you ask, were you insured for the entire year, it goes down. But if you just ask, are you insured today, that's what that number refers to.
Yep. I'll add on the cost side, a whole variety of analyses have come to the conclusion that probably the biggest reason costs are so much higher in the US than other countries is not administration, it's not malpractice or whatever. It's what gets broadly defined as kind of the technological imperative. So because people don't see the costs of things, they want kind of the newest, coolest thing. I mean, and why wouldn't you, right? There was a period of time, I think they got rid of it, but there was a period of time where there was quite seriously a mobile MRI at the California base of the Heavenly Ski Resort. I'm not kidding, right? And I had an ACL tear repaired by the lovely people at Kaiser Redwood City, and it just made me laugh with that mobile MRI there, because you come down right on the little toboggan, and they're going to MRI you, and they're going to X-ray you too, I'm sure, because the X-ray is going to show you something the MRI didn't. That makes no sense. Right there. Because what are we going to do? Like, do your ACL repair there at the slope side? I mean, no, it's because they could bill somebody for it. And because you don't care, because you're only going to pay this little emergency copay or this urgent care copay, you're not going to actually pay what it costs to do the MRI. And, darn it, I want my MRI right now. How many times have you heard a friend of yours say that about their health plan? Now, going through a more organized system, where I came home because I wasn't going to go demand it right away. I came home, I called Kaiser, they said, yeah, we should get you into physical medicine. It's nice that you've been icing it and elevating it for a couple days. Went into the DO. The DO did whatever it was that she did to bend my leg and said, yep, I think you have a tear. I think you need an MRI now. And if so, then you're going to go to, I'm going to want you to get a surgical consult. I mean, so there was no messing around with, oh, you're going to have to wait 3 weeks for an MRI. There was, there was no messing around with, we only authorize 6 physical therapy visits, and then you're going to have to come back to the doctor for another authorization. I could still go to physical therapy if I wanted to, even though it's been more than a year. And so, but there was a philosophy there of, yeah, we're going to get you what you need, but we're not going to like jump through hoops to get it for you. We're not necessarily going to respond to, I want it right now. And Americans do have this mentality of want it right now, and the whole reimbursement system supports that, right? There's an MRI practically in every street corner. You get people marketing, oh, just go in and get a whole body scan, what the heck, right? Even though we know that that's not beneficial, that that's actually detrimental to you for that, it gets marketed, people figure it's covered by their insurance, they demand it, they get it. And, and that's where this lack of financial awareness actually results in things that make us worse off and cost a ton of money while we're at it. And that's the thing that gets very tricky to control, right? If you try to control it through too much of a bureaucracy or a government mandate, then you get people saying, oh, they're trying to establish death panels. Give me a break. And if you, try to do it too much through, kind of a hodgepodge, semi-tax protected, semi-market-based system, you don't get it. You don't get what you want either. And, and that's where I think the awareness of the costs, I think educating people won't do enough for that. I think at some point you do have to make people aware that, yeah, the reason your taxes for Medicare will go up at some point is because it costs so darn much money for this stuff. And you're seeking you're seeking disc surgery for your neck before doing physical therapy because it's insured and there's a surgeon who's happy to sell it to you, as opposed to really being aware of, well, I could try this physical therapy course and 90% of the time it's going to work, and then I will have more money to help my grandkids go to school.
We have no evidence that we can get this to work in the way that the theory says. Although I would be open to the idea that we pick some particularly bad offender procedures, like MRIs is often mentioned, and consider putting a patient obligation onto that, and really highlight it, that if you want an MRI at this time, this is one of the 4 things that our single payer system in California does not automatically approve because it's way overused, and frankly, I don't think you need it. If you want to spend $500, you can get it. That might be interesting to do that, but I also just want to say that single payer will not allow MRIs at the base of ski areas, but will give everyone free season passes in the
You're touching on basically rationing, which I think is the biggest way that cost can be contained in a single payer system, and it's sort of, I think it's in most single payer systems it's it sort of has to happen because at some point, and some of the problems that people complain about denial of coverage by their insurance company, at least when that happens in a private system, they have a legal recourse to pursue. But if the government is not only the payer, but also determining the coverage, if you're denied that MRI for your neck, and it turns out you are in the 10%, and now you have a permanent neural deficit, you don't have anyone to go to appeal. The government says, no, that's not covered because our evidence shows that 85% of people respond to this. And so if you're an outlier, you're pretty, you're in a world of hurt. But so I don't disagree that there should be a safety net, and I maybe don't disagree so much with even the idea of a single payer system, but where I have a problem is the government also becoming the insurer of record and determining what must be covered, what benefits must be offered, what will not be covered.
Single payer does occasionally resort to explicit rationing, in particular if there's evidence that some procedure or surgery or diagnostic test is way overutilized. But in general, that is not the approach that single payer uses to control technology use. The way it usually works is there are controls on capital investment, which would include MRIs, for example. So if the evidence suggests that what you need in order to have good access to MRI services is one MRI, I'm making this up, per 500 people. That's what the system will pay for. And the system will then make sure that doctors are aware, as they should be, of the benefits, and whoever's running the MRI gets a request for an MRI for a questionable indication. That person running the MRI has the option to say, that radiologist or whatever has the option to say, that seems like it might be helpful. But the fact is we have 8 MRIs stacked up today that are for really urgent problems. This is going to have to wait. And that's the level at which, it's not an explicit top-down decision. It's you limit resources, you establish a global budget, you establish reasonable numbers of these expensive items, and you let the clinicians and others on the ground figure out what's a reasonable use. And it turns out that much as we've all seen doctors misbehaving, that doctors, given the opportunity to provide quality care within a reasonably resourced system and facing some constraints, do a pretty good job. That's what the evidence says, that you can limit the number of specialists, you can limit the numbers of MRIs, et cetera, and doctors will work within that pretty well. And that's the model. Thank you very much for listening, for your great questions. I'm happy to answer questions afterwards if you want. I am jgkahn@ucsf.edu.
There you go.
See you around work.
Yeah, see you at the ranch.